we have talked about placenta and the molecules formed by the placenta in detail. Now let's talk about placental anomalies. Now in placental anomalies, most of the time, beta, you are going to be asked image-based questions where you will be given images and you will have to identify the anomaly. That's one thing which they could ask you. The second thing is, in this topic only, I'm going to talk to you about the methods of placental separation and the signs of placental separation, right? So there could be question which can be asked on methods or signs of placental separation. So coming to placental anomalies. So normally, where is the placenta located? The placenta is located in upper uterine segment. If placenta is located in lower uterine segment, LUS stands for lower uterine segment, then that is what is called as placenta previa. That's a placenta previa, right? Now, second thing. Normally, chorionic villi, I told you, they are attached to endometrium, right? Now, if chorionic villi are attached to myometrium or to serosa, then such a placenta will be called as placenta accreta spectrum. That condition will be called as placenta accreta spectrum, right? The placenta is called as morbidly adherent placenta. Morbidly adherent placenta. Now, when we talk about placenta accreta spectrum, in placenta accreta spectrum, there can be three conditions. If the villi are superficially attached to myometrium, they are superficially attached to myometrium, then the condition is called as placenta accreta. Right? If the villi are deeply attached to myometrium, villi deeply attached to myometrium, then it will be called as placenta increta, right? And if the villi, they are attached to serosa, right? Then that is what is called as placenta percreta. Right? So we can have placenta accreta, increta, and percreta. Right? Now, see, normally a placenta will be having it will be a single placenta. Now suppose placenta is divided into two parts, right? And both the parts are roughly the same and they are connected by blood vessels. Can you see the blood vessels over here? So the placenta, I want you to draw it like this. Placenta is divided into two parts, right? And there are connecting blood vessels in between. Now, first of all, look at this image A over here and tell me, why am I saying that it's a single placenta which is divided into two parts? Why am I not calling it as the placenta of twin pregnancy? Why am I not saying this is a placenta belonging to twin pregnancy? This is because in placenta belonging to twin pregnancy, you will always have two umbilical cords. Always two umbilical cords are seen. Right? So, that is why I know this is not a placenta of twin pregnancy. This is a placental anomaly. Now, if you see that placenta is divided into two parts and both the parts are connected by blood vessels, then that is what is called as placenta bilobata. So if a placenta is divided into two roughly equal parts. And both parts are connected by blood vessels. That's a placenta bilobata, right? On the other hand, if you see that placenta is divided into two parts, one part is small, the other part is big, and they are connected by blood vessels, then that is called as placenta subcinturiata. So if the placenta is divided into two parts, right, one big and other small, the small one is called as subcinturiate lobe, right? So you can see SL written over here, that's a subcinturiate lobe, right? And the parts are connected, by blood vessels, right? They are connecting blood vessels. Then this is called as placenta subcinturiata. Placenta subcinturiata. Now, what can be the possible complications of placenta bilobata and placenta subcinturiata? One complication could be a retained placenta, retained lobe of the placenta. So it could be that one lobe of the placenta comes out and the other lobe remains inside. And when there is a retained lobe of placenta, that is going to lead to PPH, right? Number two, because the size of the placenta, the relative size of the placenta, one complication could be a retained placenta, retained lobe of the placenta. So it could be that one lobe of the placenta comes out and the other lobe remains inside. And when there is a retained lobe of placenta, that is going to lead to PPH, right? Number two, because the size of the placenta, the relative size of the placenta increases, so there are increased chances of placenta previa, right? It could be that a part of the placenta is lying in the lower uterine segment, and even if a part of the segment is lying, if the part of the placenta is lying in the lower uterine segment, that becomes a placenta previa. In other words, there are increased chances of antepartum hemorrhage. If there is a retained lobe of placenta, there are increased chances of postpartum hemorrhage, right? So these are the complications which can happen with placenta bilobata and with placenta subcinturiata, right? Now, normally, please understand, normally, fetal side of the placenta is 4/5 and maternal side of the placenta is 1/5, right? Now suppose there is a placenta in which maternal side of the placenta is bigger than the fetal side. Maternal side is bigger than fetal side, right? Such that the maternal side surrounds the fetal side in the form of a ring. Sorry. Right? So for example, suppose my this hand is the fetal side, this side is the maternal, this hand is the maternal side, right hand is the maternal side, left hand is the fetal side. Now, suppose this fetal side, because it is small, the maternal side is surrounding the fetal side in the form of a ring. Right? This is what is called as extracorporeal placenta. So, in the form of a ring, and this is what is called as extracorporeal placenta. Now, so suppose this over here is the fetal side, the green color is the fetal side, right? And the light blue color is the maternal side. So maternal side is surrounding the fetal side in the form of a ring. Now, please understand that if this transition is smooth, right? So if the transition between fetal side and maternal side is smooth, then such an extracorporeal placenta is called as circummarginate placenta. Circummarginate placenta. On the other hand, when the fetal side is surrounded by maternal side, so imagine, see, to the fetal side, what was attached? To the fetal side on its sides, the membranes were attached. Now, when the maternal side is surrounding the fetal side, these membranes come in between and they form a valve-like thickening, right? Then instead of calling it as a circummarginate placenta, you are going to call it as a circumvallate placenta. V for valve, V for vallate. So here the fetal side is surrounded by maternal side, but while the fetal side was surrounding the maternal side, a valve-like thickening is present in between. So between maternal side and fetal side, you are getting a valve-like thickening. This is a valve-like thickening. Right? So the blue color was maternal side, green color is fetal side. So this is what is circumvallate placenta. Circumvallate. So what do you understand by circumvallate? Now, if there is a valve-like thickening, if there is a valve-like thickening between the fetal side and maternal side, then that's a circumvallate placenta, right? Now, both in circumvallate and circummarginate placenta, please understand that because fetal side is small, right? So less blood is going to the fetus side, and that is why it can lead to IUGR. Again, circumvallate and circummarginate placenta can lead to antepartum hemorrhage, right? So, and that is why it can lead to IUGR. Circummarginate placenta, please understand that because fetal side is small, right? So less blood is going to the fetus side, and that is why it can lead to IUGR. Again, circumvallate and circummarginate placenta can lead to antepartum hemorrhage, right? So over here, do you see this over here is the fetal side. This is the fetal side of the placenta. This is the maternal side of the placenta. And do you see this valve-like thickening? Right? Do you see this white color area? A prominent valve-like thickening. So because there is a valve-like thickening, This is called as circumvallate placenta, right? Now, on the other hand, look at this image. In this image, this over here is the fetal side and this over here is maternal side, and there is just no valve-like thickening, right? There is no valve-like thickening. There is no valve-like thickening, right? And that is why this is a circummarginate placenta. Now, I know sometimes you find it difficult to understand circumvallate and circummarginate. Whenever you are in confusion, there are two tricks which you are going to apply. Number one, please understand that in circummarginate placenta, the level of fetal side and maternal side will be the same. In circumvallate placenta, the fetal side is slightly depressed than the maternal side, number one. Right? Number two, remember, more common is circumvallate placenta, and most of the time the examiner has pictures of circumvallate placenta. So whenever you are in confusion, a better guess or a better bet would be circumvallate placenta, right? Okay. Now, coming to umbilical cord insertion. Normally, where is the umbilical cord inserted? Normally, the umbilical cord is inserted to the center of fetal side of the placenta. So normally, suppose if this over here is the placenta, right, the cord will be inserted to the center of the fetal side of the placenta. Now, coming to abnormalities of cord insertion. Number one abnormality of cord insertion could be if the cord, instead of getting attached to the center, if the cord is attached laterally, right? So there can be lateral insertion of the cord. Whenever, so if the cord is inserted laterally to the placenta, right? If the cord is inserted, so if you cannot understand laterally, you can write it. If the cord is inserted to one side of the placenta, if the cord is inserted to one side of the placenta, that is a better way how you're going to remember it, right? Then it is called as lateral insertion of the cord, and such a placenta is called as Battledore placenta. Such a placenta is called as Battledore placenta. Now look at the image which I have here for you. Do you see that the cord is inserted laterally to the placenta? Are you seeing? So this is what you are seeing, that the cord is inserted laterally to the placenta, and you can see that there is not just one cord, right? There are two cords which are present over here. So this is a multi-fetal pregnancy placenta, and here the cord is inserted to one side of the placenta. It is not. Ideally, it should have been present here like this in the center. But here I am seeing that the cord is present on one side of the placenta. So I am going to call it as lateral insertion of the cord or Battledore placenta. Very, very oftenly asked image-based question. Now, next condition. Next problem could be a velamentous insertion of the cord. What do you understand by velamentous insertion of the cord? Velamentous insertion of the cord means, suppose this over here is the placenta and this over here was the umbilical cord. Now, umbilical cord is not directly attached to the placenta. First of all, in case of velamentous insertion, the cord is not directly attached to the placenta. Cord is attached to the membranes, right? Instead of attaching directly to the placenta, the cord is attached to the membranes first. In the membranes, the cord is going to lose its connective tissue. The connective tissue of the umbilical cord is called as Wharton's jelly. So umbilical cord is going to lose its Wharton's jelly, and the blood vessels which are present in the umbilical cord, they are going to go directly and they are going to get inserted onto the placenta. This is what is velamentous insertion of the cord. So first let us write this down, then I'll discuss other aspects of velamentous insertion of the cord with you. So what happens in velamentous insertion of the cord? The cord is not directly attached to the placenta. Cord is not directly attached to the placenta. The cord is first attached to the membranes. Cord is first attached to membranes. In the membranes, the cord loses. In the membranes, the cord loses its Wharton's jelly, its connective tissue, which is called as Wharton's jelly, and then the vessels directly get attached to the placenta, and then the vessels directly get attached to placenta. Right? Now look over here. This over here was the cord. This is the placenta. These are the membranes. Now you can see that the cord has not gone and attached directly to the placenta. Cord is attached to the membranes. In the membranes, the blood vessels have separated and the blood vessels are going and getting attached to the placenta. So see over here, I'm raising so that you can see properly. Just see, understand that these are the membranes and these are the blood vessels. Right? Now, understand this with the help of one more diagram. So in this diagram, this over here is the uterus, this is the placenta, these are the fetal membranes. Now, what is happening is that the cord is going and attaching to the membranes first. In the membranes, the cord is losing its Wharton's jelly, and then the vessels are going and getting attached to the placenta. This is what is velamentous insertion of the cord. Now understand that suppose a female who has velamentous insertion of the cord, she goes into labor. All of you know that whenever a patient goes into labor, sooner or later the membranes have to rupture. Now, whenever the membranes are going to rupture, because the cord is attached to the membranes, so not only will the membranes rupture, the cord will also get ruptured. And when the cord is going to get ruptured, cord has got umbilical artery, umbilical vein. So what is going to get injured? Umbilical artery and umbilical vein will be injured. And when umbilical artery and umbilical vein will be injured, bleeding is going to happen. And that blood will be fetal blood which is going to come out. Right? So when there is velamentous insertion of the cord, it can lead to a condition which is called as vasa previa. Right? What happens in vasa previa? In vasa previa, there is fetal blood loss. And from where is this blood going to come? Okay, it belongs to the fetus. But from where it is going to come? It is going to come from the mother's vagina. Right? So many times you might get confused between placenta previa and vasa previa. But first, let us write it down. So velamentous insertion of the cord, it can lead to a serious complication. It can lead to a serious complication which is called as vasa previa. Right? Now, what is vasa previa? Now, in vasa previa, so I'm going to talk to you about the pathophysiology of vasa previa. We will talk more about vasa previa after this, but first let's talk about the pathophysiology of vasa previa. Now, what is happening in vasa previa? In vasa previa, it is most commonly seen with velamentous insertion of the cord. Now, in velamentous insertion of the cord, whenever the membranes will rupture, whenever the membranes are going to rupture, right, the cord which is attached to the membranes, the cord which is attached to the membranes will also rupture. Now, because the cord will rupture, therefore there will be blood loss from umbilical artery and umbilical vein, because cord contains umbilical artery and umbilical vein, right? So there will be blood loss which will be happening from umbilical artery and umbilical vein. This is fetal blood loss, right? And this is what is called as vasa previa. Right? Understood? So let's talk more about vasa previa. Now, what is the problem in vasa previa? In vasa previa, the problem is that there is fetal blood loss, right? And this fetal blood loss comes out from mother's vagina. So there is fetal blood loss which is going to come out from mother's vagina. Please remember, vasa previa leads to perinatal mortality. It leads to perinatal mortality and not maternal mortality. Right? Now, most commonly, vasa previa, see, till a very long time back, we thought that vasa previa happens only due to velamentous insertion of the cord. But later on, we realized that vasa previa is not just limited to velamentous insertion of the cord. It can happen with other conditions also. I will tell you what are the other conditions where vasa previa can happen, but because most commonly it happens with velamentous insertion of the cord, and that is why when vasa previa is happening due to velamentous insertion of the cord, it is called as type 1 vasa previa. So what do you mean by type 1 vasa previa? Which happens due to velamentous insertion of the cord. Right, this is the most common type of vasa previa. Then type 2 vasa previa is when vasa previa is happening due to placenta subcingulata or placenta bilobata. Now understand, this is the velamentous insertion of cord leading to vasa previa. Now understand, suppose there is a placenta subcingulata. In placenta subcingulata, there are two parts of the placenta. So over here is the first part of the placenta. There is a bigger lobe of the placenta. And suppose over here is the smaller lobe of the placenta, right? And both parts are connected via blood vessels. So there are blood vessels which are connecting both the parts of the placenta. This is the umbilical cord. Now, if it is a situation like this where there is a subcingulate lobe and the blood vessels which are connecting both the lobes of the placenta are passing over the internal os. Now, because the blood vessels connecting both the lobes are passing over the internal os, same thing. When the membranes are going to rupture, these blood vessels are going to get injured, and these blood vessels have fetal blood, and so again there is going to be fetal blood loss. So this thing both the lobes like this where there is a subcingulate lobe and the blood vessels which are connecting both the lobes of the placenta are passing over the internal os. Now, because the blood vessels connecting both the lobes are passing over the internal os, same thing. When the membranes are going to rupture, these blood vessels are going to get injured, And these blood vessels have fetal blood, and so again there is going to be fetal blood loss. So this is an example of subconjugate lobe causing vasa previa. This was filamentous insertion of the cord causing vasa previa. Right? So type 2 vasa previa is when it is happening due to placenta subconjugata or it is happening due to placenta bilobata. Now, type 3 vasa previa. Type 3 vasa previa means when it is happening due to placenta previa, and this is rare. Right? Now, in vas filamentous insertion, please remember vessels are not surrounded by Wharton's jelly, so the risk of compression is going to increase, and this is going to lead to two things. Because the Wharton's jelly is not there in filamentous insertion, so there are high chances that the cord will get compressed. And if the cord will get compressed, you tell me what is going to happen to the fetus. There will be fetal distress. Wharton's jelly is not there in filamentous insertion, so there are high chances that the cord will get compressed. And if the cord will get compressed, you tell me what is going to happen to the fetus. There will be fetal distress. Right? So in filamentous insertion, there are high chances of fetal distress. Now, whenever the cord of the baby gets compressed, whenever and due to any reason, whenever the cord of the baby gets compressed on CTG, you will get variable deceleration. Variable deceleration is seen. Undergraduate bachas, just write it down. You will understand when I tell you CTG. Right? Whenever there is cord compression, due to any reason, on CTG, the finding which you get is variable deceleration. Now, because there is no Wharton's jelly and because the risk of compression is there, that is why there are increased chances of rupture of the vessels, because the vessels are not surrounded by any Wharton's jelly, leading to vasa previa. So filamentous insertion of the cord can lead to cord compression, right? And because of cord compression, there can be fetal distress. Because of cord compression, there are increased chances of rupture of the blood vessels because it is not surrounded by any Wharton's jelly, and that will lead to vasa previa. Right? Now, what is the investigation of choice for vasa previa? The investigation of choice for vasa previa is Doppler ultrasound. What is the management? So whenever antenatally, in antenatal period, if vasa previa is detected, right, then you have to go for elective cesarean section. Then you have to do elective cesarean section between 34 to 37 weeks. Please remember, vaginal delivery is contraindicated in vasa previa. Similarly, ARM, artificial rupture of membranes, is contraindicated in vasa previa. Now, this is the theoretical knowledge which I have given you about vasa previa. Now comes in your questions how you are going to know that they are telling you to make a diagnosis of vasa previa. What are those hints in the questions which will tell you that you are dealing with vasa previa? So if your question says that the patient is in labor and everything is normal. Your patient is in labor, there was a G2P1 female who was in labor, everything was normal. Suddenly after ARM means artificial rupture of membranes. Suddenly after artificial rupture of membranes, or if the membranes rupture spontaneously, there is slight bleeding plus there is fetal distress. If this is the question which is coming to you, that during labor, if the patient came to you in labor, everything was normal. Suddenly, once the membranes got ruptured, whether they got ruptured artificially or whether they got ruptured spontaneously, there was bleeding and there was fetal distress. This means that you are dealing with vasa previa. Please understand, Bachcho. Whenever the membranes rupture and there is fetal distress, right? Whenever your question says that membranes were ruptured and there was fetal distress, it could be only two things. It could be either the cord has prolapsed, right? Or it could be a case of vasa previa. Now, cord prolapse means, number one, there won't be any bleeding, right? So there won't be any bleeding. Number one. Number two, cord prolapse can be seen. The cord can be seen lying outside. Cord can be seen lying outside. If the question says that bleeding is present and there is fetal distress, or if question is not telling you that the cord is lying outside, this means you are dealing with vasa previa. In cord prolapse, you are never going to get fetal bleeding. Are you understanding? You will get fetal distress, but fetal bleeding will not be present. And cord can be seen. Now, in this case, the question is simply telling you that everything was normal, membranes were ruptured, there was bleeding and fetal distress. It means they are talking about vasa previa. The other thing which I want you to know is that in case of vasa previa and in case of placenta previa, in both, there will be bleeding, which is painless. Right? There is no pain in abdomen in both these conditions. So now, how am I going to know whether I am dealing with placenta previa or whether I am dealing with vasa previa? Please remember, in placenta previa, only if there is significant blood loss, only if there is significant blood loss, then it leads to fetal distress. Normally in placenta previa, fetal heart sounds are normal. Whereas in vasa previa, because it is fetal blood which is coming out, because it is fetal blood loss, hence question will say bleeding was less, but there was marked fetal distress. There was marked fetal distress. Or the term which can be used by your question is, it could be that fetal distress was out of proportion. Fetal distress was out of proportion to the blood loss. Whenever your question is saying this, that there is painless bleeding, the fetal distress is out of proportion to the blood loss. This means bleeding happened less, but there is marked fetal distress. You have to but you think about vasa previa. Please highlight this. This is how in your clinical questions you are going to pick up hints that whether am I going to mark vasa previa or whether am I going to mark placenta previa. And these are the concepts which you have to build, right? See, everyone who is going to give the exam will be knowing the types of placenta previa, they will be knowing what is vasa previa. But when it comes to clinical question, the concepts become very important, and that is why I focus on watching the main videos, right? Because in revision videos, again, we can't touch upon all these aspects. These aspects can be done only when I am teaching you in detail, right? So understand this. Very, very important. Now, this is how clinically we come to know whether we are dealing with vasa previa or whether we are dealing with placenta with previa, which in any case are very close differential diagnosis, because in both of them patient is going to come to you with bleeding in third trimester. In both of them patient comes to you with bleeding in third trimester, and this bleeding is going to be painless bleeding. Theoretically, there is a test which is available which can differentiate vasa previa and placenta previa, and this is called as the APT test, or this is called as Singer's alkali denaturation test. Singer's alkali denaturation test. Now, the reagent which you use for this test is an alkali. You either use potassium hydroxide or you use sodium hydroxide. The principle behind this is that in vasa previa, there is fetal blood loss. There is fetal blood loss, and fetal blood has HbF. This HbF is resistant to acids and alkali. Right? On the other hand, in placenta previa, there is maternal blood loss. Maternal blood or any adult has got HbA, right? And this HbA is sensitive to acids and alkali. Now, what do I mean by sensitive to acid and alkali and resistant to acid and alkali? Resistant to acid and alkali means it is not going to hemolyze in presence of acid or alkali. So whether you add an acid, whether you add an alkali, it will remain the same. Hemolysis is not going to happen. But when I say sensitive to acid and alkali, what does that mean? This means that if you add an acid or if you add an alkali, the blood is going to denature, it is going to hemolyze, right? So what do we do? In this case, the procedure what you are going to do is you are going to take the blood coming out from mother's vagina, whatever blood is coming out from mother's vagina, into a test tube, right? And then you are going to add potassium hydroxide or sodium hydroxide, which is the reagent. So I have shown two test tubes in one, so I'm going to add potassium hydroxide. Obviously, you're going to take one test tube only, but because I want to compare the results, that is why I have shown you two test tubes with, with blood, right? So what I have done, I have added potassium hydroxide. Now, if you see that on adding potassium hydroxide, the color of the blood does not change, right? It remains red. That means it is HbF, and that means it is vasa previa. This is what is called as APT test positive. Positive for what? Positive for fetal hemoglobin. On the other hand, if you see that on adding potassium hydroxide, the color of the blood changes and it becomes brown in color. It becomes brown in color. This means that it is HbA, and that means you are dealing with placenta previa. When it becomes brown in color, it is called as APT test negative. I just want, see, principle all of you will remember, result all of you will remember. What you forget is what is APT test positive, what is APT test negative. APT test positive means it is positive for fetal hemoglobin. That means if it remains red, you are going to call it as APT test positive. If it becomes brown in color, you are going to call it as APT test negative. So see over here, these are the two test tubes, and over here, this is the vasa previa solution, which is sodium hydroxide in this case. And After adding blood, if the color remains the same, if it remains red in color, that means it is HbF and that is apt test positive. If it becomes brown in color, that means it is HbA and that is apt test negative. So this is how you can differentiate vasa previa and placenta previa theoretically, right? Now, there is another test which is based on the same principle, that is HbF is resistant to acids and alkali and HbA is sensitive to acid and alkali, and that is Kleehor-Betke test. So there are two tests which you are going to study in entire OBS which are based on this principle. Now first let me talk to you about, let's fill up the apt test column because you know about it, and then I'll come to Kleehor-Betke test. Now apt test, the other name for apt test was Singer's alkali denaturation test. Singer's alkali denaturation test, right? Now this apt test is used to differentiate between placenta previa and vasa previa. Test. Singer's alkali denaturation test or apt test is a qualitative test. It tests in RH between fetal blood and maternal blood. Right? On the other hand, we have a similar test which is Kleehor-Betke test. The other name for Kleehor-Betke test is acid elution test. Its use is to calculate the dose of anti-D in Rh negative pregnancies. So in Rh negative pregnancies, when I have to give anti-D, to calculate the dose of anti-D, we use Kleehor-Betke test. Now, as the name suggests, it's an acid elution test. So the reagent used will probably be an acid, and that is citric acid phosphate. Calculate the dose of anti-D, we use Kleehor-Betke test. Now, as the name suggests, it's an acid elution test. So the reagent used will probably be an acid, and that is citric acid phosphate buffer. Now, because it is calculating the dose of anti-D, so it is a quantitative test. And this is the best test which differentiates between fetal RBC and maternal RBC, right? So that is apt test and Kleehor-Betke test. Now, coming to fetal hematopoiesis. When we talk about fetal hematopoiesis, please remember that the first site for fetal hematopoiesis is the yolk sac. Yolk sac is the main site till less than 6 weeks of pregnancy, and when it is the yolk sac which is the main site for hematopoiesis, the hemoglobin which are formed are GOVR1, GOVR2 and Ortland hemoglobin, right? Then liver becomes the main site between 6 weeks to 20 weeks, and when liver is the main site, then the hemoglobin which is formed is HbF. Then bone marrow starts producing HbA beyond 20 weeks. But that doesn't mean that beyond 20 weeks, liver will not produce HbF, right? Liver will continue to produce HbF, but beyond 20 weeks, bone marrow also starts producing HbA. The hemoglobin of the newborn will be 16 to 18 grams per dl. In this 16 to 18 grams of hemoglobin, HbF will be 95%. But once the baby is born, 6 months after birth, HbF will be only 1%. And that is how it happens in adults also. In adults also, HbF is less than 1%, right? So this was all about the fetal hematopoiesis. It was all about the placental anomalies and the cord anomalies. Some other important things which you need to know are about placental separation. Please remember, placental separation occurs in the of labor. And human placenta, as I told you, is deciduate, which means it has to separate. Whether I do anything or I don't do anything. Human placenta after delivery, it has to separate. And the line of separation or the plane of separation of the placenta, it runs along zona spongiosa. It runs along zona spongiosa. Now, there are two methods of placental separation. Draw these two diagrams. One is the Schultz method and the other one is Duncan's method. So in Schultz method, placenta is going to separate from the center so that whatever bleeding is happening behind the placenta and there is formation of a retroplacental clot. So first I'm going to talk to you about Schultz method. So what has happened in Schultz method? In Schultz method, placenta separates from the center. A retroplacental clot is formed. Now, bleeding, please remember, is going to be seen. Blood loss or bleeding will be seen only after the complete placenta has separated. So, bleeding is visible only after complete separation of placenta. Right? The amount of blood loss is less due to the formation of a retroplacental clot, and whenever the placenta will separate, it is the fetal side of the placenta which is going to come out first. So the side of the placenta which comes out first is the fetal side, and how are you going to remember it? Please remember S for Schultz and S for shiny fetal side. So it is the shiny fetal side of the placenta which is going to come out first. Schultz method is the more common method of placental separation, which is seen in 80% cases. Now comes the second method of placental separation, which is Duncan's method. In Duncan's method, placenta separates from the periphery. So whatever bleeding is happening is coming out immediately. There is no retroplacental clot formation, and that is why amount of bleeding is more. And in this case, it is the dull maternal side of the placenta which is going to come out first. So write it down. Placenta separates from periphery. Right? Retroplacental clot is not formed. Bleeding is visible as soon as placenta separates. Right? Amount of blood loss is more, and it is the maternal side of the placenta which is going to come out first. How are you going to remember? Please remember D for Duncan and D for the dull maternal side. Right? So it is the dull maternal side which comes out first, and it is less common, seen in 20% cases. So these are methods of placental separation. What are signs of placental separation? Please understand, so suppose this over here is the uterus and this is a placenta which is attached to the uterus, and the cord of the placenta comes up till here. Now this is a placenta same placenta which has separated. It is now lying over here, and this is the cord. Right? So the signs of placental separation. Number one sign of placental separation is the most common method of placental separation is Schultz method. And the moment the placenta, there will be complete separation of placenta, what is going to happen? The entire blood is going to come out. So there is going to be little separation. And the cord of the placenta comes up till here. Now this is a placenta same placenta which has separated. It is now lying over here, and this is the cord. Right? So the signs of placental separation. Number one sign of placental separation is the most common method of placental separation is Schultz method. And the moment the placenta, there will be complete separation of placenta, what is going to happen? The entire blood is going to come out. So there is going to be a gush of blood. A gush of blood is seen. Right? Now, when the placenta is going to separate, it is going to lie in the lower uterine segment. So there is going to be a suprapubic bulge. there will be a suprapubic bump, right? Now, when the placenta is going to separate, it is going to lie in the lower uterine segment. So, there is going to be a suprapubic bulge. There will be a suprapubic bulge is seen, right? Now, please remember one point which you are going to remember, which is a PYQ also. What is the height of the uterus immediately after delivery? Many times this question has been asked whether it is NEET or FMGP. So height of the uterus immediately after delivery is, it is just below the umbilicus. It is just below the umbilicus, corresponding to 20 weeks of pregnancy. Right? And that is where you should be trying to feel the fundus of the uterus after delivery. After delivery, you will find that the uterus is just below the umbilicus, that is corresponding to 20 weeks of pregnancy. Now understand. As I told you, the most common method of placental separation is Schultz method. And in Schultz method, bleeding is not seen till the entire placenta is separated. Now, once the entire placenta is separated, that entire blood which was collected behind the placenta, along with the placenta, is going to come and drop in the uterus. And because they are going to come inside the uterus, the height of the uterus will slightly increase. So there is a slight increase, blood which was collected. As I told you, the most common method of placental separation is Schultz method. And in Schultz method, bleeding is not seen till the entire placenta is separated. Now, once the entire placenta is separated, that entire blood which was collected behind the placenta, along with the placenta, is going to come and drop in the uterus. And because they are going to come inside the uterus, the height of the uterus will slightly increase. So there is a slight increase in the height of the uterus. Fourth and the most important sign, all of you pay attention over here. See, when the placenta was attached, this was the place till where the umbilical cord was coming. The moment placenta separates and it comes in the lower uterine segment, the umbilical cord can be seen coming up till this level. In other words, it appears as if the length of the cord has increased. And this increased length of the cord is permanent. No matter how much you push the uterus up, the cord is now not going to go back, right? So there is a permanent plus apparent. So actually the cord has not increased in length, right? Earlier, because the placenta was attached, the cord was coming up to this level. The moment the placenta is separated, it appears as if the cord has lengthened, right? So there is a permanent plus apparent increase in length of the cord. Very, very important sign. Now, if you get a question that which is the surest sign of placental separation, the surest sign of placental separation is if placenta can be felt in vagina on per vaginal examination. So if you can feel the placenta in vagina on per vaginal examination, that's the surest sign of placental separation. But if that is not given in the options, then the second shortest sign is permanent plus apparent lengthening of the cord. Permanent plus apparent lengthening of the cord. Right? So these are signs of placental separation. Clear to all of you? Yes? This is all what I want you to know on placental anomalies, signs of placental separation and methods of placental separation. Take care. See you in the next video.